handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
So, hi guys! So, welcome to another episode of Top Notch Genesis, no? So, ngayon, ang i-discuss naman natin is the remaining topics sa pathology. So, allow me to introduce myself again. So, naturuan ko na yung similar batch, no? Kayo rin yun, for Genesis Physiology. I am Doc Imran. You can call me Doc Im, or Im for short, no? I graduated from ASMPH and took the boards nung October and November 2021, no. I also got my undergrad degree for pharma sa UP and also taught for the past 6 years, no, for the pharmacy board exam. So ngayon, med boards naman. So without further ado, no, simulan na natin yung discussion for the remaining topics. So ngayong gabi, or kung kailan nyo man pinapanood to, no, i-discuss natin yung from kidneys, the lower urinary tract pathologies, the male and female reproductive pathologies, and as well as the breast pathologies. Right? So let's start with the kidneys. So for the kidneys, ito yung magiging set of topics natin: the glomerular diseases, stones, incontinence, urinary tract infections, acute kidney injury, and the tumors. Okay? So the flow of the discussion will be more of, I'll be giving a clinical picture, no? And then dadaanan natin yung mga different important pathologies behind it. Kasi ganun nakastructure yung buong board exam, no? Meron siyang clinical question, and then you have to at least diagnose. And then the question is not what is the diagnosis? It's more of ano yung mga parang follow-up questions behind it. So we'll give some few high-yield information regarding the different pathologies. Okay? So let's start with your kidney pathologies, no? So for the kidney pathologies, kung makikita nyo dito sa picture, no, we will go through the different set of pathologies, no, from microscopic. For example, dun sa may nephron, dun sa glomerulus natin, dito sa part na to, as you can see dun sa in-highlight ko. And then the different pathologies in the whole urinary tract system, kunwari mga stones, as mentioned earlier, yung mga different neoplasms, isa-isahin natin lahat ng mga yan. Okay? So, una natin gagawin is just a quick rundown of the clinical manifestations. No? Again, kapag nakita niyo yung format ng slide na ganito, no, it's more of say, I want you guys to be able to answer, no, kung nasan man kayo. So sa practice, it's like a quiz, no, para at least na practice niyo yung inyong memory and recall, kasi it's good na magkamali ngayon kaysa magkamali kayo sa boards or sa mga future practices ninyo. Okay? So kapag kunwari sa clinics or sa hospital, napansin nyo yung laboratories ng patient, no, mataas yung BUN, mataas din yung creatinine. So you call that, may proper term for that, that's called as your azotemia. Okay? There are different kinds of azotemia. So we have the following sets, no, yung naka-indent dyan. Yung meron tayong associated with renal hypoperfusion, which is known as your pre-renal azotemia, di ba? Kapag intrinsic diseases naman ng kidney, for example, pathologies within the kidney itself, you call that naman your renal or intrinsic azotemia. Kapag naman sinabing may problem or may obstruction dun sa flow ng urine or distal to the kidney, okay? After the renal pelvises, no? You call that your post-renal azotemia. And you call azotemia kapag meron siyang clinical manifestations na associated with it. What do you call it now? It's called uremia. Okay. So, next, kunwari sa clinics, napansin ninyo na yung GFR ng patient rapidly declined in a span of few hours lamang, no? Tapos meron pa siyang dysregulation ng fluid. Or ano ba yung mga dysregulation ng fluid na yan? Pwedeng paliguria, anuria, and electrolyte imbalances or changes, no? And ang keyword dito is rapid decline. So what do you call that? We call that AKI. Okay, so ang keyword, mabilis yung decline. So in IM, no, in the future, i-discuss yung mga different sets of guidelines, no? Paano mo mako-consider na AKI siya? So we discuss yung KDIGO guidelines natin. But for now, at least alam ninyo na rapid decline of GFR with dysregulation of fluid and electrolytes, that is AKI. Okay? So, ano naman difference niya with CKD? So usually kasi pwedeng mag-overlap yung dalawang yan, no? Pwedeng AKI on top of CKD. Pero CKD, by definition, that should be a GFR of less than 60 ml per minute per the body surface area nung patient. Okay? And then, if the GFR is less than 15%, you call that already your end-stage renal disease. Okay? So makikita nyo yan sa KDIGO guidelines yung different classifications, no, ng kidney disease natin. Okay, so yan yung mga important clinical manifestation. So paano naman kung yung pasyente, sabi niya, Doc, meron po akong masakit yung dito sa may suprapubic, sa may dito sa puson area, no? Tapos nilalagnat daw siya, tapos pinakuhanan niya siya ng lab, nakita niya na merong pyuria or meron din siyang sinasabing flank pain, no? In general, no, these constellation of symptoms, no, pertain towards your UTI, no? Yung UTI natin, later on, i-classify natin siya further. Kung cystitis ba siya or pyelonephritis. At this point, gusto ko lang makita nyo yung big picture. Okay? Kunwari naman, the patient, sabi niya, Doc, sobrang sakit nung dito sa may flank area ko. Tapos pag ginawa mo yung test for CBA tenderness, no? May pain na na-elicit. And then, kapag ganun yung manifestation, ano yung consideration mo? You can consider stones. Okay? So to help us with the diagnosis naman, we have to ask for additional laboratories, no, to help us clinch the diagnosis. So ito yung mga important laboratory findings na dapat alam ninyo para at least mas makuha natin, ma-sure natin na ito talaga yung diagnosis for that patient. Kunwari, dun sa laboratory, humingi ka ng urinalysis, no? Nakita mo na may hematuria pero walang cast na present. Ano yung consideration mo kapag ganon? You can consider kidney stones or bladder CA. Kasi remember, for example, ito yung tubules mo. Okay? Tapos kunwari may stone. Pag nagasgas niya yung gilid or yung tubules, di ba? It can cause leakage ng blood. Okay? So in the form of hematuria. Pwede rin na may bladder CA. Okay? Ano naman kapag merong pyuria or pus in the urine pero walang cast na present? Ano yung consideration niyo? Pwede siyang UTI, di ba? In the form of acute cystitis. So at this point, naka-highlight dito sa may lower part ng screen natin. Sabi ko dyan, important, kapag may nakita kayong cast, ibig sabihin, ang source ng pathology is glomerular or tubular in origin. Okay? And the first two na diniscuss ko sa inyo, okay, walang cast na present. So, hindi ka magko-consider ng glomerular or tubular in origin. Now next, dahil alam nyo na yon, paano ngayon kung merong RBC cast na associated? Ano yung consideration ninyo? Okay? It can be due to glomerulonephritis. Okay? Ano ba nangyari? Kapag may glomerulonephritis? Pwedeng, no, nasira yung basement membrane. So later on papakita natin and magli-leak ngayon yung ating red blood cell. Remember, dito sa ating glomerulus, kung ito yung afferent arteriole ninyo, di ba, anong dumadaan dyan? Arterioles, it's blood. Okay? And remember that urine is what? An ultrafiltrate, di ba? Filtrate siya ng blood ninyo. So, kapag hindi na-filter out yung ating blood, yung mga RBCs dyan, magli-leak sila. Punta sila dito. Diba? Pupunta sila sa tubules. And dahil masyado madami, for example, na nag-leak na RBCs dito sa may tubules, didikit-dikit sila, it will form a cast. Okay? So, kaya yun yung reason why you consider GN or glomerulonephritis kapag may RBC cast. You can also consider hypertensive emergency. No? Kapag hypertensive emergency, if you recall, di ba, mataas yung blood pressure plus meron siyang organ damage. Okay? In this case, kidney damage. Next naman, puntahan natin, what if the patient manifested with WBC cast? Pag WBC cast, di ba? Remember, in inflammation, in basic pathology, di ba? Kapag may inflammatory condition dun sa area, kunwari may inflammation or may infection dun sa area, di ba? Magre-release yung mga cells ng cytokines para tumawag ng mas madaming WBC. And ano mangyayari? Lalapit sila, di ba, dun sa area. So, yung mga WBC mag-iipon-ipon dun sa area na yun, forming WBC cast, which can be associated with your tubulointerstitial inflammation. Diba? Inflammatory. Acute pyelonephritis. It's an infection which can initiate, di ba, more WBC to go near dun sa area. Pwede rin transplant rejection. Next naman, for example, nagkaroon ka ng granular cast. Pag granular cast, you will consider acute tubular necrosis. Okay? Later on, malalaman natin further ano ba yung granular cast na yan. Okay? And lastly, fatty cast. Pag nakita nyo sa labs, sa urinalysis, meron fatty cast, you will consider nephrotic syndrome. Kasi pag nephrotic syndrome, ano nagli-leak? Pwedeng mag-leak yung mga lipids, no? Dun sa tubules. So forming a fatty cast. Okay. Next, other important laboratory findings. So yung nasa A na yan. Okay, that's an example of an RBC cast. Okay. So na-discuss na natin yan. And then yung letter B na nandyan sa picture, this one. This is a WBC cast. This is acute tubular necrosis, no? Granular cast, muddy. It's muddy brown in color. And then this one, for the fatty cast, no? May multi-cross formation, for the spillage of your lipids in the tubules. Okay? Next, we now go to the glomerular diseases. For the glomerular diseases, so simulan natin dun sa ano ba yung nangyayari sa glomerulus kapag nagkaroon ng injury dun sa glomerulus, no? So we discuss first the glomerular response to injury. So ito, yung picture na to, gusto ko lang i-emphasize na yung mga yan, isa-isahin natin sila kung ano yung affected based dun sa pathology. So for example, nagkaroon ka ng acute injury to the glomerulus, no? Ang pwedeng manifestation niyan ay hypercellularity. Okay? Sa hypercellularity, pwedeng magka-proliferation of cells, no? Particularly yung mesangial and endothelial cells. Nasaan yung mesangial cells ninyo? This one, and also this one, yung endothelial cells ninyo. So kapag ka-acute injury dun sa glomerulus, ano daw yung dadami? Pwedeng dumami yung mesangial cells, pwedeng dumami din yung endothelial cells. Next, paano kung kunwari sinabi, basement membrane thickening, is it acute or chronic? Okay? Acute or chronic? This is chronic. Kasi, remember, di ba, parang isipin mo hindi naman agad-agad magtitiken yung inyong basement membrane. Okay? Nasaan ba yung basement membrane nyo? Itong hina-highlight ko dito. Okay? Yung color red. Kapag naman hyalinosis or sclerosis, it's also chronic, di ba? So matagal yung pathology na nakastay na dun sa glomerulus, kaya nagkakaroon ng hyalinosis and sclerosis. Okay? So, balik tayo dun sa hypercellularity saglit. So, kapag ka sinabing hypercellularity, ano yung mga associated conditions? Okay? One of the associated condition ay ang tinatawag nating PSGN. Or post-streptococcal glomerulonephritis, no, associated kapag nagkaroon ka ng strep throat or skin infection, tapos nagkakaroon ka ng nephritic syndromes. Okay? So later on, i-discuss natin yan. Okay? And also, it is also associated with your crescent formation. Okay? Example ng nagbibigay pathology na nagbibigay ng nagma-manifest with the crescent formation is your RPGN, no? Your rapidly progressing glomerulonephritis. Okay? And then, associated condition naman with your BM thickening is your membranous nephropathy. No? And then, your hyalinosis and sclerosis. Syempre, sclerosis yung word. No? You have your focal segmental glomerulosclerosis. Okay? So, anong difference pala ng hyalinosis and sclerosis? Kapag sinabing hyalinosis, okay, pag sinabing hyalinosis, eosinophil yung dumadami. Pero kapag sinabing sclerosis, collagen naman yung dumadami. Okay? So in this picture, pinapakita lang natin, okay, ito ay hypercellularity, no? Dumami yung mga cells, acute or chronic yung condition. It's acute, no? This is your PSGN. This one naman, makikita nyo may mga sclerosis, okay? Collagen deposition. This is your focal segmental glomerulosclerosis. Next, you have this one. So makikita nyo yung mga arrow. Sorry, masyadong malaki yung pointer. Pero makikita nyo yung arrow, no? Kumapal yung basement membrane. And in that picture, pag kumapal yung basement membrane, acute or chronic? That is chronic. So this is an example naman of your membranous nephropathy. Okay? It's okay if at this point no medyo naguguluhan pa, pero later on I hope no magiging mas clear na pagka diniscuss na natin siya in detail, no. Another bonus picture, this one sa ito nasa baba. Makita nyo dito, this is a crescent, 'di ba? Formation. Nabanggit ko kanina, this is associated with what condition? Your RPGN. Okay? Kapag crescent formation, acute or chronic? It's acute. Okay? It's an acute response to inflammation. Okay. Next, gusto kong maintindihan naman ninyo kung ano yung mga different patterns of glomerular diseases. Okay? We have global, okay, and segmental. Kapag sinabing global, okay, ang affected ay lahat. Okay? Lahat nung glomerulus. Remember, pag global, buong, okay, glomerulus. Okay? Pero kapag segmental, ang affected lang ay part or segment, okay, based sa word ng glomerulus. The keyword between global and segmental ay glomerulus lang yung affected. Anong difference niya with the next set of slide? Okay? Focal and diffuse. Kapag sinabing focal, ay hindi lahat ng glomerulus ay affected. Pwedeng, kunwari, itong part lang, 2 lang out of 5. Okay? Kunwari, total number ay 5 lang. No? So, gets ba? Parang hindi lahat ng glomerulus ay affected. Pero pag sinabing diffuse, okay, the keyword is lahat ng glomerulus in the whole kidney, no, is affected. So remember those things, no? Diffuse, lahat ng glomerulus. Focal, piling glomerulus. Okay? Kapag global, buong bilog ng glomerulus, kapag segmental, part lang ng glomerulus. Okay? So those are the patterns of glomerular diseases. It's important to know those things kasi later on, mas madali siya kapag kaniname na natin sila isa't isa. Okay, so let's now go deeper. So kanina, na-discuss na natin yung glomerular response to injury, no? So tignan na natin ngayon yung nephritic and nephrotic, the classic nephritic and nephrotic na laging tinatanong sa boards, no, or mga different exams. So kapag ka nephritic, remember, highlight ninyo yung letter I. It's for inflammatory. Okay? Inflammatory, I, nephritic. Kapag sinabing nephrotic, podocyte. Okay? Podocyte. Okay? Ang affected doon ay yung podocyte. Okay? So kahit yun muna yung intindihin natin. Okay? So kapag ka sinabi nating nephritic syndrome, so let's go further. So, inflammatory siya, di ba? Pag sinabing inflammatory, may kita ninyo doon sa picture na ang damage ay, okay, dahil doon sa inflammation, may kita ninyo na naka-blue yung ating basement membrane dito sa area na to. Okay? And that damage to the basement membrane, okay, will cause the leakage of your RBCs. Okay, ngayon lumabas na yung RBC ninyo sa inyong urine. So therefore, para mas madali nyo maintindihan, nasira yung basement membrane. Sabi ni nung resident niya, for example, sabi niya, pakuha naman ng urinalysis. Before lumabas pa yung urinalysis results, okay, ano na yung iisipin mo? Meron siyang manifestation ng hematuria. Okay? Pero may hematuria siya. But particularly, meron siyang cast formation. Kasi, di ba, ang sabi ko, nag-leak yung RBC, syempre may ipon yung RBC dun sa tubule. Pag naipon yon, magiging siyang cast. Now, imagine, for example, nabara ngayon yung RBC cast doon sa tubule. Okay? Anong mangyayari sa urine output? Okay? Bababa. Okay? Therefore, meron siyang ngayong oliguria. Okay? So, iisipin ngayon nung kidney ninyo na, di ba, nagka-oliguria ka, tapos dahil nakabara, mag-i-increase yung pressure dun sa tubule, yung GFR mo ngayon ay tataas or bababa? Bababa. Kasi parang, sabi niya, puno na dito. Hindi na niya kaya mag-filter. Okay? So, yung GFR mo ay bababa. So, therefore, kapag bumaba yung GFR, yung kidney matritrick siya na parang, konti yung blood flow na dumadaan sa akin, okay, na pumupunta sa akin. Anong gagawin niya? It will stimulate the release of renin. Okay? Kasi akala niya mababa yung blood volume eh. So, release renin, ma-activate ngayon yung RAAS, di ba? Renin, angiotensin, di ba? And aldosterone. Okay? So, ano nangyayari? So, ma-stimulate ngayon yung renin, angiotensin, and yung aldosterone. So, ang aldosterone will cause, di ba, reabsorption of sodium, and where sodium goes, di ba, water follows. Therefore, ano mangyayari? Tataas yung blood volume, and in the end, tataas din yung blood pressure. Okay? Tapos meron ka pang angiotensin, which is a potent vasoconstrictor. So kapag kinonstrict mo yung blood vessel, ano mangyayari sa blood pressure? Tataas or bababa? Tataas din. Hence, kunwari pinamonitor ka ngayon ng residente mo sa isang pasyenteng may nephritic syndrome, anong ina-expect mo sa vitals niya? Meron siyang elevated blood pressure. So that's how you remember, no, yung nephritic syndrome rather than memorizing it. So at least nagigets ninyo na nasira yung basement membrane, yung main pathology behind it. Okay? Pwede rin bang magkaroon ng proteinuria with nephritic syndrome? Pwede, pero not as high as that of your nephrotic syndrome. Okay? So ngayon, differentiate natin with your nephrotic syndrome. Kapag sinabi namang nephrotic syndrome, so look at the screen, no? Ano nga yung damage ulit? Yung ating podocyte. So as you can see dun sa picture, okay, yung podocyte yung affected. Yung podocyte ninyo, remember that it is, okay, it is involved, no? Para siyang charge, para siyang barrier na may charge. And remember that your proteins are negatively charged, diba? So parang in a way, nagkakaroon ng pag-repel dun sa pag-spill ng protein dahil may podocyte ka dyan. It's a charged barrier. Okay? Now, in nephrotic, nasira si podocyte. Pag nasira si podocyte, ano ngayon may imagine, makikita mo sa urinalysis ng may nephrotic syndrome? Magkakaroon ka ng massive proteinuria. Okay? Ano ngayon yung appearance ng ating urine? Kunwari in the clinical history, ano kaya ikukwento ng patient mo sa'yo? Pag umihi siya dahil may proteinuria, anong itsura ng bibi niya? Frothy urine. Okay? Next, in the physical examination, ano kaya yung makikita ninyo dun sa pasyente ninyo? Okay? Balikan natin. Meron siyang proteinuria. The major protein in the blood is albumin. Diba? And your albumin helps in parang keeping the water inside the blood vessels, diba? In the whole circulatory system. Pero ngayon, wala kang albumin, natapon sa urine. Ano mangyayari doon sa tubig or tubig na nandun sa blood vessel ninyo? It will leak out. So what will happen dun sa anong itsura ngayon ng pasyente mo? They are edematous, no? So kapag pumunta ka sa wards, nakita niyo sila, okay, yung paa niya namamaga or yung kanyang mga eyes namamaga. Okay? And then, what else do you need to watch out for? Kunwari, tinanong kay na residente, o anong kailangan nyo i-monitor sa pasyente na to? Okay? Kailangan i-monitor niyo siya for any signs of thrombosis or any signs of infection. Bakit? Kasi yung mga protein na yan, di ba? For example, yung mga tawag dito, yung mga IgAs, di ba? Yung mga immunoglobulins, they are leaked out of the system. Okay? So, natatapon sila sa urine, therefore, higher possibility na magkaroon ng infection yung pasyente. Okay? And also the proteins that are required for clotting, okay? Natatapon din sila. So, therefore, pwedeng magkaroon ng signs or watch out for signs of thrombosis. Okay? So, let's now go on to the different types of your glomerulonephritis. Okay? Para mas madali nyo silang ma-memorize, hinati ko sila into this picture. Okay? Sinumarize ko sila sa picture na yan. So, makikita nyo na lahat ng mga nephritic syndromes natin ay merong GN sa dulo. Okay? Maliban sa ating membranous nephropathy or membranous glomerulonephritis. Siya lamang yung nag-iisang nephrotic syndrome. Okay? So, ganun nyo na lang siya i-picture muna at this point. Okay? Nephritic, lahat ng GN, plus lahat ng may A. Okay? IgA, Alport syndrome. Okay? Kahit i-memorize nyo lang yung nephritic, the rest, okay, are nephrotic. But I want you to remember that your DPGN or your diffuse proliferative GN and your MPGN can be both, okay, nephritic and nephrotic. Okay, so isa-isahin natin sila in the next few slides. Okay. So clinical pearls. Kunwari, sabi nung pasyente, nagkaroon siya ng throat infection mga 3 weeks ago, skin infection din. And then, after a few weeks, nagkaroon yung, parang sabi niya, parang tiyaan na po yung aking ihi. Okay? Tapos tumaas yung blood pressure niya. What will you consider? That is PSGN or post-streptococcal glomerulonephritis. Paano naman, in the history, kausap mo yung pasyente, meron daw siyang SLE. What will you consider? Your diffuse proliferative GN naman. So, naka-green siya, di ba? To help you recall that it can be nephritic or nephrotic. Okay? Paano naman, kunwari, in the history, sabi ng patient, nagka-hematuria siya. So, reddish-colored urine, no? And then, umuubo siya ng dugo, no? You consider your good pasture syndrome. For me, ang memory recall ko dyan, pasture, di ba parang green grasses, ganyan. Tapos na-imagine ko yung person, or farmer nga eh. Ayan. Na umuubo. Okay, umuubo siya dun sa mga grass ng dugo. Ayan. So, good pasture syndrome. Hematuria, tapos umiihi din siya ng dugo. Ayan. And hemoptysis. So, good pasture syndrome. Next, can't see, can't pee, can't hear a bee. Can't see, so meron siyang mga retinopathy, no? So, ito yung triad ng tinatawag nating Alport syndrome, di ba? Meron siyang triad ng retinopathy, can't see, can't pee kasi di ba glomerulonephritis. So, it's pwedeng oliguria or anuria, ganyan. And can't hear a bee kasi meron silang sensory neural deafness. Okay, so that is your Alport syndrome. Okay, kapag ka naman in the history, nabanggit niya na pwedeng may Hep B or Hep C infection siya, you will consider your MPGN. So recall nga lang ulit para matandaan ninyo, ano nga yung nag-iisang GN sa nephrotic? It's your MGN or your membranous nephropathy. Okay? So iba siya sa MPGN kasi lagi nalilito yung mga tao dyan. And actually, if I remember it right, no, merong similar question sa boards na nagtanong, ano yung ganitong type of glomerulonephritis? Is it nephritic or nephrotic? Okay? So those are your clinical pearls. Ngayon, paano mo siya ma-differentiate histologically? So in histology, no, pwede mo siyang ma-differentiate by light microscope. Yan yung LM. IF or immunofluorescence, and then EM for electron microscopy. Okay? So if the patient, yung histology, no, hypercellular, tapos starry sky, no, subepithelial humps, ang inyong differential or main diagnosis should be PSGN. So important to take note, subepithelial humps, okay, for PSGN. And hypercellular, again, acute or chronic? That is acute response, diba? Next. Ayaw. Next. So pag kunwari crescent moon shape, na-remember nyo kanina, ano yun? Acute or chronic? It's acute, diba? And saan siya makikita yung crescent moon shape appearance? Sa RPGN. Okay? And yung RPGN, okay, it can be the parang outcome of 3 different pathologies which can be differentiated by their immunofluorescence. No? Pwedeng linear, negative immunofluorescence, or granular. Pag linear, no, you will consider good pasture syndrome. Okay? Good pasture syndrome, di ba? Hemoptysis and your hematuria. If you remember kanina, yung drinowing natin. And then negative IF, you will consider Wegener's, mga Churg-Strauss, ganyan. And granular for PSGN and DPGN. Okay? Kaya ko sila tinabi sa RPGN kasi itong tatlong ito, pwede silang mag-progress to RPGN. Okay? Maliwanag ba? Pero ma-differentiate mo lang yung tatlo based sa kanilang IF. Okay? Next. So ito lang yung mga just a quick preview. So itong picture na to, this is your PSGN. Ito yung starry sky ng ating PSGN, and this one is your RPGN, the crescent moon shape. Okay? So next, other histological differentiation ng ating mga differentials, no? We have wire looping sa LM and granular naman sa IF, that is your DPGN. So, hinighlight ko na dyan yung wire looping. Pag narinig nyo yung wire looping, that is DPGN. Next, mesangial proliferation. Pag narinig nyo yung mesangium, di ba pinakita ko na sa inyo kung nasan yung mesangium kanina? Okay? It's better nga to look at the glomerulus, di ba? Tapos, kung aling part yung nagkakaroon ng pathology, sulatan niyo na nung mismong condition. For example, mesangial proliferation, this should help you recall na IgA nephropathy naman siya. Okay, mesangial IgA nephropathy. Next, pagka in EM, basket weave pattern narinig nyo sa EM, that is your Alport syndrome. Okay? For Alport syndrome, ang important to remember in this pathology, no, na-imagine ko siya para nasa airport ka, kunwari ito yung airplane, kunwari airplane yan. Okay? Doon sa floor nung airport, okay, meron kang basket na makikita. Bakit important na nasa floor? Kasi ang affected dyan ay yung basement membrane. Yung collagen type 4, okay, collagen type 4 ng basement membrane, and yung appearance niya ay basket weave appearance. Okay? And yung airplane, it will help you remember airport. Sounds like outport. Okay? So yun yung basket weave pattern naman in PM. And tram track sign, okay, this will be associated naman with your MPGN. Yung tram track, naalala ko dyan yung LRT. Yung LRT laging hindi gumagana, di ba? Hindi gumagana. Okay? And, di ba, minsan nasa stock lang siya. Ayun, dyan kasi yung MRT and LRT. Okay? Kapag nasa stock lang siya sa kanyang relays, so hindi siya gumagana, sana naman mapagana naman siya. Okay? Mapagana. Okay? So I hope this will help you remember, no, yung tram track sign, no, for MPGN naman. Okay? Itong mga pinakita ko dito sa screen, no, these are just a few of the important histologic differentiation. Pero meron pa silang mga other manifestation na nakalagay dun sa chinek ko ngayon. Okay? But yung highlight ko, yun yung very important na characteristics nila. Okay? That you should focus on. Okay, so this one, that is your DPGN. Itong naka-highlight na to. So again, that's your wire looping. And then this one, this is your tram track sign. Ano nga yung tram track sign? Tram track, track for LRT, di ba? Yung track relays ng tren. O yan, relays ng tren. Kay mapagana or MPGN. Alright? So I hope that helped you, okay, remember and recall. Okay. Next, punta na naman tayo sa mga clinical pearls for your nephrotic syndrome. Okay? So pagka nephrotic syndrome naman, sabi natin kanina, ano yung damage? It's your podocyte, di ba? Pagka podocyte, it's a charge barrier, di ba? And it does not permit the passage of protein. Pero pag nasira, magsispill yung protein. Hence, nephrotic syndrome. Okay? Nephrotic for protein. Okay? So, paano kunwari, patient nag-present with nephrotic syndrome, tapos yung age niya ay bata. Okay? What's your main consideration? That should be minimal change disease. Okay? Paano pagka in the history, it's triggered by an infection, immunization, okay? Tas nabanggit na meron siyang immune problems, immunodeficiencies, for example. And then, idiopathic yung manifestation, bigla-bigla lang nangyari, you will also consider minimal change disease. Okay? Remember the 4 I's of MCD. Okay? And then, kunwari, the patient naman, pumunta sa'yo, may known case of HIV or known case na may sickle cell disease siya or heroin abuse. Okay? Pag ganito yung clinical history, consider FSGS. Okay? Your FSGS. And kapag HBV or Hep B or Hep C and syphilis infection, consider naman your membranous nephropathy. Diba? Your membranous nephropathy, kanina nabanggit ko, it's the only GN na nag-ending sa GN. Diba? It can be kasi, it can also be called kasi membranous glomerulonephritis or membranous nephropathy. Okay? So pag nag-end sa GN, it's usually nephritic, except for MGN, okay, which is nephrotic. Okay, so yan yung mga clinical pearls. And then histology, so let's differentiate lang yung ating mga nephrotic syndrome. Pag effaced podocyte, narinig niyo foot process, automatically that's minimal change disease. Okay? Pag narinig niyo yung sclerosis, hyalinosis, similar din siya sa MCD, that is your FSGS. Ano bang ibig sabihin ng FSGS? Focal segmental, 'di ba? Glomerulosclerosis. And yung keyword mo sclerosis, 'di ba? So LM pa lang malalaman mo na FSGS na siya. Kapag GABM is and diffuse, nagkaroon na thickening, ng GBM and yung mga capillaries mo, okay? And meron kang spike and dome, okay, appearance na subepithelial in origin, no, you will consider naman your membranous nephropathy. Okay? So ang keyword mo dyan actually is your GBM, no? Yung glomerular basement membrane. So membranous nephropathy, nagtitiken yung ating basement membrane. Okay? So, yan. Paano naman, kunwari sa light microscopy with Congo red stain, no? Nagkaroon ng apple green birefringence in polarized light, you will consider your diabetic glomerulo nephropathy. Okay? So, yeah. So, ito yung ating yung letter A natin. So, may kita nyo dito, effaced foot process. So ano yung ating pathology? Sorry, ano nangyayari? Sorry. So yung ating pathology, pag effaced foot process, minimal change disease. Okay? Tapos, bumalik na tayo doon. Ito, as you can see earlier, diba? Focal, diba? Ito yung buong glomerulus mo. Focal, segmental, glomerulosclerosis. Sclerotic area to. So this is FSGS. And this one, so nag-thicken yung basement membrane. This is your membranous nephropathy. Okay? So clear na ba? Kaya na bang i-differentiate ang mga ating glomerulonephritis? No? So pwede na natin malaman kung nephritic ba siya, nephrotic, or both. Diba? Yeah. So that's it for the different glomerular pathologies. Just a quick rundown, no? So diniscuss natin kanina sa sa start yung mga glomerular responses, no? So yung kung acute ba siya or chronic ba siya, di ba? So try nga natin, mag-answer kayo in your own places, no? Pag hypercellularity, acute or chronic? That is acute. Kapag sclerosis, is it acute or chronic? That is chronic. Okay? Tapos diniscuss din natin yung mga different types or patterns ng glomerular diseases, di ba? Meron tayong global, meron tayong segmental, di ba? Pag global, buong glomerulus, segmental, part lang ng glomerulus. Ano yung dalawa pa? You have your focal and your diffuse. Pag focal, onte lang na glomerulus yung affected. Pag diffuse, lahat ng glomerulus ay affected. Okay? And then we also discuss yung difference ng nephritic and nephrotic. Nephritic, tuloy, I, okay, for inflammatory. Nephrotic, O for podocytes, di ba? Nephritic, inflammatory. Ano yung affected pag may inflammation? Yung sa nephritic, yung basement membrane. Pag nawala yung basement membrane, ano mangyayari sa RBC? Magli-leak. Pag na-leak yung RBC, ano itsura sa urinalysis? May RBC cast ka. Pag nagkaroon ng RBC cast, ano mangyayari sa GFR? Dahil bumara, bababa yung GFR. Akala ni kidney, mababa yung flow. Pag akala niya mababa yung flow, tataas si renin, mas-stimulate si RAAS. And in the end, magkakaroon ng hypertension. Diba? Next, paano naman kapag nephrotic? Nephrotic, podocytes. Diba? Pagka podocytes nasira, magsispill si protein. Pag nag-spill si protein, pwedeng mawala si albumin. And si albumin, di ba, anong ginagawa niya? It holds the water inside the blood vessels. So pagka nawala yung water sa blood vessel, magkakaroon ka ng edema. Okay, very good. So yun yung ating mga different types of nephritic and nephrotic. Diniscuss din pala natin yung mga different types ng nephritic and nephrotic syndromes natin, di ba? Sabi ko, pag may GN sa huli, that is nephritic, no? Kapag except for your membranous nephropathy or your membranous glomerulonephritis din. So also called as membranous glomerulonephritis. Okay? Tapos daanan lang natin mabilisan. Kunwari sinabing subepithelial humps, you will recall PSGN, di ba? Basket weave, ano nga ulit yon? Alport, di ba? Remember, basket na nasa floor ng airport, di ba? And then we have your tram track. Pag tram track, di ba? Recall LRT. Hindi na gumagana laging LRT. So remember, mapagana or MPGN. Okay. Next, punta tayo sa stones. So for the stones, so bumaba na tayo dun sa kidney, no? So nandun na tayo dun sa may ureter area or dun sa pelvises area ng kidney. So pagka stones, I summarize them in this table, no? I want you to draw this table on your own, no? Tapos isulat niyo lahat ng stones in their alphabetical order, no? Pero ang ginawa ko, C, di ba? C, S, U, tapos ito, Y na to. Okay? So para mas madali. So bakit ganyan yung arrangement na gusto kong ipagawa sa inyo? Kasi mas madaling mag-remember. So ito, magpe-precipitate sila in high pH, meaning alkaline urine. Uric acid and cysteine will precipitate in acidic urine. Okay? Tapos the rest, okay, dito sa X-ray and CT, kunwari nag-request ng X-ray and CT scan, for patients na may suspect for stones, na-suspect for stones, okay? Remember that your uric acid, siya lang yung lucent sa X-ray. Okay? Radiolucent, meaning hindi siya nakikita. The rest, they are opaque. Okay? Ito, minimally opaque. Or minimally, parang hindi siya, pwedeng hindi siya makita. Okay? Minimally radiolucent. Okay? And then, for calcium, ano naman yung itsura ng mga crystals ng mga stones na to? So, for calcium, ang itsura niya, so, mukha siyang envelope. Okay? Mukha siyang envelope. Envelope-like. Tapos, si struvite naman, si struvite kasi, okay, it looks like coffin. Okay? Nare-remember ko siya because your struvite is associated with your, what do you call this? Yung ating staghorn calculi. Diba? Staghorn. So naalala ko sa staghorn yung parang sa deer, di ba? Ganyan yung ano niya, yung dito sa sungay niya. Okay? Ang na-imagine ko, sinungay siya. Okay, tinusok sinungay. Tinusok siya nung beer, okay? Kaya siya na deads, okay? Nailagay siya sa coffin. So ganun ko siya na-remember. And then yung uric acid, it's rhomboid, okay? Rhomboid in appearance. And your cysteine naman, it looks like a hexagon. So 6 sides ang hexagon, di ba? 16. Alright? So those are for your different stones. Okay? So I hope na-copy ninyo kanina. Okay, next. Buzzwords lang. What is the most common stone? It's your calcium stone. Kapag in the history nabanggit ethylene glycol, nakainom siya or accidentally nakainom siya ng ethylene glycol, you will consider calcium stone then, particularly your calcium oxalate. Okay? Pagka ano naman yung diuretic na ginagamit for calcium stones? These are your thiazide diuretics. Kasi remember, sa thiazide diuretics, one of their side effect ay hypergluc, di ba? Hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Bakit? Kasi, kunwari ito yung nephron mo. Ang weird na drawing ko. Kunwari ito yung tubule, loop of Henle. Ito yung ating collecting duct. Your thiazide, what it does is nire-reabsorb niya si calcium from the tubules. Okay? Kaya nagkakaroon ng hypercalcemia. Okay? And effective yon for calcium stones kasi hindi dadami yung calcium dito sa tubules. Okay? Kaya hindi magpe-precipitate si calcium. So yun yung diuretic na kailangan yung tandaan. And next, this is associated with urease positive organisms, no? Struvite stones. Okay? Ano yung mga urease positive organisms natin? Your Proteus, ganyan, your Staph saprophyticus, yan. So ano bang ginagawa ng mga urease positive? Hinahydrolyze nila yung urea to ammonia. Okay? Tapos pag ammonia, ano siya? Basic or acidic? It is basic. Mataas or mababa yung pH? Mataas, di ba? And kanina, ano sabi natin? Ang struvite, magpe-precipitate out siya sa high pH. Okay, very good. Next, leukemia. it is associated with uric acid stones. Okay? Bakit uric acid? Remember, sa leukemia, high cell turnover, di ba? Madaming cell na napoproduce, madami ring cell na namamatay. And pag namatay, di ba, sa loob ng cell, pag namatay yung cell, yung cell meron siyang nucleus, nandun yung DNA. Your DNA consists of purines and pyrimidines, di ba? Purines, pagka degrade mo siya, nagiging siyang uric acid. Okay? So yun yung reason bakit associated with leukemia. Okay, next topic, incontinence. Okay? Lumabas to sa boards namin sa PrevMed. Okay? About incontinence. May lola daw na agad-agad naiihi, okay? Kapag ka tumatawa or umuubo. Okay? So makikita natin dito, no? Kung ano yung mga different types of incontinence. Pag sinabing stress incontinence, ang mechanism of action niyan ay outlet incompetence. As you can see in the picture, no? Dito, mahina yung parang sphincter. So therefore, maalog lang. Maalog lang yung lola. Hindi, joke naman. Huwag naman maalog yung lola. Mag-ubo lang yung lola or mag-sneeze or mag-lift yung person. Hindi naman lola lagi. Okay? Or yung obese patient, okay? Nagbuhat siya. Or yung pasyente in the history may madaming vaginal delivery madami na siya na ipanganak through vaginal delivery. So, nag-weaken yung mga muscles. So, nagkakaroon ng outlet incompetence and hence, stress incontinence will manifest dun sa pasyente natin. Okay. Next, urgency incontinence naman is associated with detrusor overactivity. Ano ibig sabihin nun? So it is usually associated with urinary tract infections. So pagka may urinary tract infections, so parang meron kang hyperactivity ng muscle, yung detrusor muscle. Hence, parang dahil nasa-stimulate siya, meron kang feeling na gusto mong umihi. Okay? Kaya remember in the clinical picture of your UTI, di ba? Meron siyang presentation ng frequency. Diba? So that is for your urgency incontinence. And then overflow incontinence naman is associated with patients na may BPH or diabetic. Kasi parang meron silang incomplete emptying na nafe-feel, okay, na nangyayari. Kasi, di ba, pag BPH, dito sa, saan ba makikita yung prostate ng, saan ba makikita yung prostate ng mga pasyente, di ba, sa area na to? So kapag ka-enlarge yung prostate, okay, yung urine hindi siya agad-agad nakaka-empty. Hence, okay, madali siyang mag-overflow. Tapos dahil puno, okay, pwede mag-leak. Okay? So that is your overflow incontinence. Okay. Next, punta tayo sa urinary tract infections. Earlier, nabanggit natin yung initial manifestation ng UTI, di ba? So, ano nga ulit yung mga yon? So pwedeng may suprapubic pain, may dysuria, urinary frequency, and kanina nasabi na natin ano yung associated na incontinence with UTI, 'di ba? Yung urgency, 'di ba? The urgency incontinence na banggit natin earlier. So yan. So ano yung most common cause of acute cystitis? It's your E. coli. Kapag naman tinanong ng resident nyo, paano naman kung are sexually active young women? Okay? You will consider Staph saprophyticus. But still, okay, in this population, no, E. coli pa din. Pero you will just consider Staph saprophyticus. And sa laboratory, okay, anong manifestation yan? You will have, okay, nitrites in the urinalysis. Okay? So kapag may nitrites dun sa urinalysis ninyo, okay, that can signify the presence of gram-negative organisms. Okay, gram-negative organisms. So, pwedeng E. coli. Yan. So, which is a gram-negative, di ba? And let's differentiate your acute cystitis and pyelonephritis. Kapag acute cystitis, okay, suprapubic pain lang pero walang fever. Okay? Pero pag may fever na, flank pain and chills, you will consider pyelonephritis. Pyelo means nandun na siya dun sa may, umakyat na siya from the bladder, papunta dun sa may kidney area. So that is the difference between acute cystitis na nandun lang sa may bladder area and pyelonephritis, nag-ascend na yung infection. Kaya siya may flank pain, may fever, may chills. Okay? So that is for your pyelonephritis. Okay, so next naman, puntahan natin ang acute kidney injury. So for acute kidney injury, nabanggit natin earlier, di ba, there's a rapid decline in your GFR in a span of few hours lang, di ba? And it can be pre-renal, renal, and post-renal. So isa-isahin natin. So pag sinabing pre-renal, think of what? Decrease in blood going to the kidneys. Ano yung mga condition na nagkakos ng mababang blood flow going to the kidney? Una is hypovolemia. Okay? For example, nagkaroon ng shock, bleeding, ganyan. So, can cause pre-renal AKI. Okay? Or, for example, mababa yung cardiac output. Kailan nangyayari yun? Kapag kayong pasyente ay may heart failure. Okay? Ibig sabihin, kahit nandyan yung blood, dahil hindi napapump ni heart ng maayos yung dugo, wala masyado nakakapunta sa kidney. Okay? Next is a decrease in the effective circulating volume. Okay? Ano ibig sabihin nun? In patients na may heart failure, okay? Ibig sabihin mahina din yung cardiac output, or in patients na may liver failure, okay? Pag may liver failure ka, wala kang mababa yung production ng albumin, di ba? Yung protein, which is a protein. Hence, ano mangyayari? Sabi ko kanina, tinuro ko, pag walang albumin, yung fluid magli-leak to the peripheral tissues, di ba? And what happens pag ganun? Parang in a way, kahit yung total fluid body content, total fluid mo sa body ay same pa din, no? Ang nangyari lang, nailabas siya dun sa blood vessels. So parang isipin ni kidney, okay, wala rin pupunta na blood doon sa kidney kapag ganon. Okay? Naiintindihan ba? So, hence, heart failure, liver failure, ayan, can cause, or shock, or for example, Korean, for example, bleeding, ayan. So, it can cause, okay, pre-renal AKI. Okay? When there's pre-renal AKI, what happens is, nagkakaroon ng, okay, decreased renal blood flow and a decreased GFR. Okay? Hence, kapag kagano, di ba, akala ni kidney, walang pumapasok na blood, i-increase niya yung renin, angiotensin, aldosterone, which will ultimately cause an increased sodium and water reabsorption. So, bilang BIBO clerk ka and intern, okay, ano yung ine-expect mo kaya sa urine osmolality ng patient na may pre-renal, okay, AKI? Okay? So sabi natin, increased sodium and water reabsorption. Water na reabsorb. What happens to the osmolality of the urine? It will increase, no? So mataas yung osmolality niya. Yung urine sodium mo ay mataas or mababa? Mababa. Kasi what happened? Increased sodium reabsorption, di ba? Increased sodium reabsorption. Tas ito rin, di ba? Kaya nagkaroon ng increased osmolality kasi na-reabsorb yung water. And the fraction of excreted sodium is less than 1%. Why? Okay, important yung value na yan. Kasi meron kang increased sodium reabsorption. Okay? That will differentiate this one, your pre-renal, from the other types of AKI. So, very important. Fraction of excreted sodium. Later on, makikita nyo yung difference. Next, punta tayo sa intrinsic. Pagka sinabing intrinsic, think of the kidney itself. No? Pwedeng yung tubules, okay? Yung tubules na may problem, or the interstitium, or the glomerulus. Okay? I will just draw something here. So, pwedeng yung tubules. Kunwari, ito yung glomerulus ninyo. Yan, ito yung Bowman's. Ito yung inyong Henle. Yan. Kapag sinabing intrinsic, pwedeng yung problem ay saan daw? Glomerulus, pwedeng sa tubules, pwedeng sa interstitium, dun sa gilid-gilid na parts. Okay? Sa mga tabi-tabi. Okay? So, yun yung tinatawag na intrinsic. Okay? Pwede rin na vascular related yung problem. Okay? Pwedeng mga vasculitides. Okay? Basta intrinsic, kidney. Remember that. Okay? So, pagka yung tubules yung affected, okay, pwedeng mag-manifest with acute tubular necrosis. Okay, acute tubular necrosis. Ano nangyayari doon? For example, ito yung tubules mo, di ba? For example, ito yung So, kunwari ito yung tubules natin, as you can see. Acute tubular necrosis, nangyayari yon kapag yung tubules itself nasira. So, kunwari ito, nasira yung mga cells na nagko-compose sa tubules. So what happens? Punta sila dito. Okay? Punta sila dyan. And yung debris na yan, pag nagbuo-buo siya dyan, you call that your muddy brown cast, di ba? Your granular cast, which is associated with your acute tubular necrosis. Di ba? Naalala nyo kanina, muddy brown cast dahil nasira yung tubules. Ano yung nagkukos ng mga acute tubular necrosis? Pwedeng nephrotoxin. Okay? Kung makikita nyo sa rotation nyo sa radio, no, tinatanong yan. No? Tinatanong kung meron ba siyang or inaalam yung yung kanyang GFR. Kasi di ba, it can cause, yung contrast niyo, it can be a nephrotoxin which can cause your acute tubular necrosis, no? And then crush injuries, kunwari na nabangga, nabundol, nasira yung mga muscles dito sa, for example, sa different parts ng body niya, that will cause leakage of myoglobin, which is toxic also to the tubules. And hence, meron siyang ATN. Ano yung manifestation? Your muddy brown cast. Okay, you differentiate ATN naman with AIN. Your AIN is your acute interstitial nephritis, and meron 5 P's of your acute interstitial nephritis that is due to P as in wee, P, okay, pain-free for NSAIDs, okay, P for penicillins, okay, another P for PPI, and last is rifampin. Okay, rifampin. Okay, again, the 5 P's of AIN. So P for diuretics, pain-free for NSAIDs, penicillins, okay, PPIs, and then your rifampin. Okay, so yun yung different types of intrinsic injuries natin. Okay? Also, remember kanina, yung shock, di ba? Sabi natin, that can cause a decreased blood flow to the kidneys and can cause, sabi natin, pre-renal AKI. But remember that it can also cause your intrinsic AKI. Bakit? Kasi di ba remember, kailangan, para mabuhay yung cell, kailangan niya ng constant supply of oxygen. And pag walang constant supply of oxygen due to low blood volume, what will happen? Masisira yung cell, mamamatay siya. So parang ganun lang din yung mechanism. Pag nasira yung cell, masisira yung tubules. So it can cause ATN, then acute tubular necrosis. Hence yung shock or hypovolemic shock can cause pre-renal and renal azotemia. Okay, so those are your acute kidney injuries na pre-renal and renal. Okay, and sorry. Yan. So ano yung ina-expect natin ngayon doon sa laboratory findings natin? Okay? So balikan natin yung pathophysiology. Sabi natin kanina, kunwari ATN to ha. This is your tubule. Yan. So pag nasira, 'di ba, yung ating tubule, yung mga cells, 'di ba? Anong ina-expect mo sa urine osmolality? It should be low. Okay? It should be low. Kasi hindi naman nagkakaroon ng water reabsorption, water sodium reabsorption. Kasi nasira yung tubule eh. Gets ba? So dahil nasira, yung water nandito lang. Okay? Yung mga sodium nandyan lang sa lumen. Okay. What happens to the urine sodium? Okay? Mataas yung level ng sodium kasi wala ng reabsorption dahil nasira yung tubules. And the fraction of excreted sodium should be high or low? Tingnan nyo, nasira yung tubule. It should be high, okay? Greater than 2%. So that's the reason why I let you remember na this differentiates it from pre-renal azotemia or acute pre-renal acute injury. Okay? And then lastly, post-renal, it should be related to outflow obstruction. So pwede siyang, ano yung mga different types ng outflow obstruction? Pwede magkaroon ka ng stone dito. So dahil may stone ka dyan, magkakaroon ng pressure, masisira. Ayan yung kidney pataas, pwedeng may neoplasm sa may bladder, pwedeng may neoplasm dito na naiipit yung ureters. Okay? So think of outflow obstruction for post-renal. So important to kasi tinatanong siya sa boards. Okay? Yan. And lastly, for your kidney topic, for our kidney topic, your renal cell carcinoma. Your renal cell carcinoma, okay, can be, meron siyang tatlong different pathology, parang histology. Okay, so RCC, renal cell carcinoma, clear cell, papillary, and chromophobe. So 3 histological appearance. Okay, it is also associated with chromosome 3. Okay, to help you remember, 3 letters RCC, chromosome number 3. Okay, and then sino ba tong artistang nandito, no? So mnemonic ko lang kasi to. To help you remember yung mga different types of RCCs, no? Itong person na to, siya si Lil Papi. Sa post, kung nanonood kayo ng post, okay? Watch niyo yung post kasi very nice siyang series sa Netflix, no? It tackles several issues, no, about yung mga rights ng different communities natin, no? The LGBT community, ganyan. And also, it increases awareness about HIV and AIDS, no? Which is very pressing, parang silent pandemic, no? Na kailangan nating matugunan bilang mga healthcare professionals. So, okay, ang dami na nating naging kwento. Pero ang gusto ko lang ipakilala sa inyo ay si Little Papi. Okay, bakit kasi yung mnemonic natin ay related sa kanya. Okay? So, remember, yung mnemonic, is it clear? Papi? Don't be a homophobe. Okay? Don't be a chromophobe. So, bakit ko pinamemorize sa inyo yun? Kasi I want you to remember it in that pattern. Okay? Kasi mas madaling gawin yung table na to in that pattern. So, clear, Papi? Don't be a chromophobe. Okay? So, because in that sequence, it will also help you remember that clear cell is the most common in incidence. Okay? The cytogenetic origin, as you can see, PCT, sunod-sunod lang DCT, and intercalated cell. So in that order then, at histology, wala na akong magagawa dyan. Yan lang talaga siya. So clear granular cytoplasm. Okay? Kasi clear cell. Okay? Clear cytoplasm. Papillary for P, papillary formation, P for Samoma bodies. Okay? And lastly, chromophobe. Okay? Halo, perinuclear halos. And chromophobe, color, ang chromo, di ba? Phobe is parang takot, kaya ang itsura niya ay pale. Di ba? Pale means no color, chromophobe. Okay? Clear ba yon? So, anong manifestation ng renal cell carcinoma? We have 3 ulit. 3 for triad. Hematuria, flank pain, and mass. Okay? Clear, Papi. Don't be a chromophobe. Okay? So, that's for your RCC. So, let's now go to the different lower urinary tract pathologies. No? We have your bladder neoplasms, your penile pathologies, and your testicular pathologies. Okay, so for your bladder neoplasm, we have urothelial neoplasm and squamous cell carcinoma. So memory aid for your urothelial neoplasm is your P-SAC. Okay, anong ibig sabihin ng P-SAC? So P for phenacetin, S for smoking, A for aniline, okay, and C for cyclophosphamide. Okay, phenacetin. Okay, phenacetin. Smoking, aniline dyes, and cyclophosphamide. Okay, so those are related to your urothelial neoplasms. Okay, it's the most common tumor of the urinary tract system. No, kahit bladder man yan, renal calyces, pelvis, ureter, ang sasagot nyo dyan ay urothelial neoplasm. Okay, but okay, if for example tinanong yung organism na andyan, okay, ano yan? It's schistosoma hematobium. Schistosoma hematobium causes a bladder neoplasm na squamous cell carcinoma. Okay? And squamous cell carcinoma is due to a chronic irritation of the bladder. No? Next, penile pathologies naman. So for penile pathologies, punan lang natin yung difference ng epispedia and hypospedia. Kapag sinabing hypospedia, nandun sa underside ng penis. Okay? Pag epispedia, epi means above, sa taas na side ng penis. Pero syempre sa boards, hindi sasabihin, nasa taas na side, nasa baba na side ng penis. Okay? So anong part yan? Ito ay yung ventral part. Okay? Ito yung dorsal part. Okay? So, baka isipin nyo, bakit baliktad? Okay? Hindi siya baliktad. Ganyan talaga. Imagine niyo, di ba, in the normal anatomical position, di ba, you are erect, nakatayo. I mean, erect meaning nakatayo ka, no? Buong body mo. Pero yung penis, nakatayo din. So, nakatayo din siyang ganyan. So, pag nakatayo, okay, nasan yung ventral part? Itong harap. Yung dorsal part, yung nasa likod. Okay? So, and para mas madali nyo rin maalala, no? E, malapit sa D. Or D kasunod niya ay E. Okay? So those are your congenital anomalies of the penis. Nung rapid review naman ng other penile pathologies, inability to retract foreskin. Ano yun? Ito ay phimosis, no? Phimosis. Ang palatandaan ko diyan dahil masyado maliit yung butas dun sa foreskin, okay? Basahin niyo yung phimosis, 'di ba? Maliit yung butas. Maliit yung butas. Phimosis. Okay? I hope it helps, no? Phimosis, an ability to retract foreskin. Next, yung glands and prepuce infection. This is known as your balanopostitis. Okay? So, bala, kasi the glands look like a bala ng baril. Di ba? Yung cup ng baril. Okay? Yung cap, hindi pala cup. Cap ng baril. Cup. Okay, bala ng baril. So, that is for your balanopostitis. Okay? Next. So, puntahan natin ang squamous cell carcinoma of the penis. So, what are the precursor lesions of your squamous cell? You have your erythroplasia of K-rat. Okay? K-rat, red plaque. Okay? Pag sinabing Bowen disease, okay? Bowen, W, white plaque. Okay? K-rat, for red. Okay? And then, it is found in the glands. Bowen disease is found naman in your shaft. Okay? So your squamous cell carcinoma is related to your HPV, particularly what strain? Your 16 and 18. Very good. Yan. So next, testicular pathologies naman. For your testicular pathologies, they can be divided into cryptorchidism, okay, testicular torsion, varicocele. So isa-isahin natin sila. So for your cryptorchidism, no, there is a failure of descent of one or both testes, meaning hindi siya bumaba, no, from the abdomen pababa dun sa scrotum. Okay? Tanong ko na lang sa inyo, yung testosterone level ba ay normal? It is normal because remember, 'di ba? Your testosterone is produced by your Leydig cells, 'di ba? And Leydig cells, they are unaffected by high temperature. Kaya remember, 'di ba? Kaya nagkakaroon ng different pathologies with cryptorchidism ay dahil yung egg na iwan siya doon sa abdominal area, which is mas mainit yung temperature doon sa abdominal kaysa doon sa scrotal area. Okay? So doon nagkakaroon ng pathologic conditions dahil doon sa higher temperatures namamatay yung mga sperm, no? Pero yung testosterone level is always normal or almost always normal, okay? Kasi yung Leydig cells ay unaffected. So if tinanong naman, what is the associated tumor with cryptorchidism? It's your GCT, your germ cell tumor. And surgery is done before 2 years old. What do you call that surgery? It's your orchiopexy. Okay? Next, testicular torsion is known as the rotation ng testicle around a spermatic cord or vascular pedicle. So anong nangyayari dito, ang presentation ng pasyente sobrang sakit, no, painful, no? And ang itsura ng testis dahil nag-twist siya, it's high riding. Kung makikita niyo, nag-twist siya, so aakyat siya ng onte, no? High riding testicle. And also, ang premasteric reflex for patients na may testicular torsion is absent. Kasi ano bang premasteric reflex, 'di ba? When you stroke the inner side of the thigh, 'di ba? What will happen? The scrotum will contract, no, para parang higpitan yung hawak dun sa testis ng human. Okay? So if for the boys, no, if you have tried this one, no, try it, no. Try it talaga. I mean, para makita nyo, para malaman nyo kung ano yung ibig sabihin ng premasteric reflex. So pag ginawa nyo, for example, sa patient na may testicular torsion, okay, hindi na siya aakyat kasi twisted na siya. Okay? So absent premasteric reflex. Okay. Next. Hindi mag-move. Okay, varicocele. Pag varicocele, meron ka namang dilated veins in the testicular sac. And it's the most common scrotal enlargement in adult male. So if the resident or your consultant ask you, now what is the associated plexus in varicoceles? You answer, pampiniform plexus. And the most commonly affected side is the right or left? It's your left. Bakit left? Kasi remember, your testicular vein, okay, drains to the left renal vein and hindi sa aorta. And with that, nagkakaroon ng increased resistance dun sa blood flow. Okay? Hence, mas madaling mag-form ng varicocele sa left. Okay? This is just a summary of the different pathologies of the testis. So, na-discuss natin yung testicular torsion, varicocele. Okay, spermatocele is a dilated ependymal duct, no? Hydrocele is water or fluid in the scrotal area. Okay. Now, punta naman tayo sa testicular pathologies. Okay? For testicular pathologies, no, particularly testicular tumors, no, pwede silang i-divide into two major parts or divisions, no? Classifications. You have your germ cell tumor and your sex cord stromal tumor. Okay? Most common, no, germ cell tumor yung associated sa testicular tumors. Okay? So, ito yung mga different types of your tumors. So, it's easier to memorize actually the following. Okay? Sertoli, Leydig, and testicular lymphoma. So for your sex cord stromal tumor. Because your sex cord stromal tumor, okay, yung Leydig, okay, nanggagaling sila sa Leydig and Sertoli. The rest, okay, yung test taking, no, pag wala siya dito, nandun na siya sa germ cell tumor. Okay? So para mas madali nyo siyang ma-recall. Now, okay, let's first discuss the different germ cell tumors. So for seminoma, okay, I want you to remember that it's the most common testicular tumor. It also appears like a fried egg appearance, okay? And then mataas din yung placental alkaline phosphatase ng ating seminomas. Okay? Next, teratomas naman, okay? I want you to remember na pwedeng may mature or immature. But if the teratoma presents in adult males, okay, and it's a mature teratoma, it may be malignant. Okay? It's the triple M's of teratoma. So, kantahin na lang natin sabay-sabay, no, para maalala natin. Tarat, 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 tarat. Okay. So, yun. So, mature teratoma, adult males may be malignant. Okay? So, teratoma. Next, embryonal carcinoma. Pagka embryonal carcinoma, ang manifestation niyan ay painful hemorrhagic mass na may necrosis. Pag yolk sac tumor, okay, the keyword here is Schiller-Duval bodies. Okay? Ang palatandaan ko dito, it's an aggressive tumor kasi, so sabi mo, Shill, sorry, let one more. Shill, you're so aggressive. Okay? Shill, you're so aggressive. So Shill for Schiller-Duval, yo for yolk sac, aggressive for her. Okay? Aggressive. Kasi masyado siyang aggressive. Okay? And then, mataas din yung AFP in your yolk sac tumors. And it's the most common testicular tumor in less than 3 years old. Okay. And choriocarcinoma is associated, has elements of syncytial trophoblast and cytotrophoblast. Kasi 'di ba, chorio, 'di ba, sounds like yung mga OB terms natin, ba, chorion and amnion. Okay, so and that is composed of your syncytial trophoblast and cytotrophoblast. Okay? Next, punta na tayo sa ating mga other types of tumors. Kung kanina germ cell tumor, nandito naman tayo sa sex cord tumor. So Sertoli cells tumor, okay? It's an androblastoma from sex cord stroma, okay? Sir Andro, okay? Remember Sir Andro, okay? So androblastoma. And then Leydig cell tumor, so, ang main pathology niyan ay, or ang buzzword kapag narinig niyo yung rain key crystal. Okay? So, recall Leydig cell tumor. So, ang mnemonic, halay, is raining. Okay? Halay, it's raining. Ha? Okay? Halay, Leydig, is raining. Okay? Okay? And then lastly, testicular lymphoma. It's the most common testicular cancer in older men. Okay? Testicular cancer in older men. And remember that lymphoma is is not a primary cancer. No, it's more of a metastasis from a metastatic lymphoma to the testis. Right? So next, BPH naman and prostate cancer. Pag BPH and prostate cancer, what is which lobes are affected? Pag BPH, it's your, so as you can see in the picture, it's your lateral lobe, okay, dito, and your middle lobe. So pag nag-enlarge itong part na to, what happens? Itong part na to, nako-compress urethra, kaya hirap umihi yung mga patients na may BPH. While prostate cancer, okay, arises from the posterior lobe. P for prostate, P for posterior lobe. Okay? And P for puwet kasi you will be able to makakapa nyo yung posterior lobe from the puwet. Kasi dyan sa puwet area, okay, pag nag-DRE kayo, you will feel yung posterior lobe. And hence, yun siguro yung reason ni God na madali mo siyang makapalpate, no? Ginawa talaga niya na dyan yung anatomy para madali mo mapalpate at malaman if yung patient ay may prostate cancer. Okay? So, what is the route of metastatic spread to the bones for prostate cancer? It's your Batson's plexus, di ba? And clinically, when do you consider METs? Kapag kapag yung patient mo ay nag-present with lower lumbar, lumbar area pain, lumbar pain, ganyan. Kasi bakit? Nag-spread out na siya dun sa lumbar spine. Okay? So that is your male pathologies. Okay. Then, punta na naman tayo sa female genital tract. So for the female genital tract, we have vulvar vaginal pathologies, cervical, uterine, and ovarian. Okay? So, start tayo sa vulvar pathology. So, from outside going in. So, first we have your Bartholin duct cyst. So, Bartholin duct cyst is just a cyst doon sa Bartholin duct, no? Kaya nagkakaroon ng enlargement, as you can see, dito sa part na to. And then next, we have lichen sclerosus. Lichen sclerosus, nagkakaroon ng thinning ng epidermis. and sclerosis. Okay, thinning ang keyword dyan, and sclerosis. And the presentation is porcelain white plaques. As you can see, porcelain white plaques dito sa my picture. And then other vulvar pathology, we have your lichen simplex chronicus. So kung makikita ninyo, lagi ako nalilito actually dito sa lichen sclerosus before and lichen simplex chronicus. Pag narinig niyo yung sclerosus, okay, think of sclerosis. Okay? So ito yung clinical manifestation. Pero pagka lichen simplex chronicus, pag sinabing chronicus, matagal na siya, di ba? So parang nagkaroon na ng hyperplasia and leather appearance. So parang siyang ang dami ng parang matagal or long-standing yung condition. Kaya yung itsura niya ay leathery. Okay? So leathery vulvar skin. But if you compare lichen simplex chronicus and lichen sclerosus, may slight risk lang for lichen sclerosus for SCC but no risk for lichen simplex chronicus. Okay? Next, vulvar pathologies pa din. So vulvar carcinoma, so HPV-related, no? Remember yung 16 and 18. Pero pagka not HPV-related, it's related to lichen sclerosus. Ano nga itsura ng lichen sclerosus? Is it thickening or thinning? It's thinning, di ba? Thinning of the vulvar area. And merong sclerosis na part or may sclerosing area dun sa vulva no patient. And lastly, we have your extramammary Paget's disease. No, it presents with pruritus, erythema, crusting ulcer, and it has a low risk of underlying carcinoma. So ang binanggit ko to dito kasi later on sa breast pathology, no, kapag narinig niyo yung Paget's disease, it's always associated with an underlying carcinoma, particularly your DCIS. Okay, so later on makikita niyo. So, pero pagka Paget's of the extramammary area, vulvar pathology, low risk of underlying carcinoma. So akyat na tayo sa vaginal area. So is vaginal carcinoma common? No, it's not. It's rare. It's usually associated or a spread from the cervical carcinoma, from a cervical carcinoma. So, pag tinanong din, what is associated with DES in utero or your diethylstilbestrol? Okay. It's your clear cell adenocarcinoma of the vagina. Paano naman kung yung mass is described as a grape-like polypoid mass in the vagina? You consider your sarcoma botryoides. So how do you remember? Botryoid means grapes. Okay? So, grapes. So, kaya yun yung itsura niya dito sa picture. So, it looks like grape-like, okay? Polypoid mass. So, your sarcoma botryoides. Now, akyat pa rin tayo from after your vagina, you will see your cervix, diba? So, cervical carcinoma naman. So, where does cervical carcinoma begin? Right? It begins in the squamocolumnar junction. Hence, di ba pag nag-pap smear kayo, saan kayo kukuha dapat? Sa squamocolumnar junction or sa transformational zone. Hindi lang kayo dot-dot ng nung anong tawag doon, yung swab, no? Kung saan-saan, no? You have to get from the cells doon sa transformational zone. Okay, what's the most important risk factor for cervical CA? It's your HPV 16 and 18. What's the pathognomonic sign for HPV? It's your coilocytes. Okay? Associated gene products ay E6 and E7. Okay? Your E6 inhibit your TP53. Okay? Your E7 inhibits PRB. Okay? Para maalala nyo, 6 and 7 magkasunod, P and R magkasunod. Okay? So, and the most common cause of death in cervical carcinoma is complication secondary to urinary tract obstruction. Bakit? Tignan nyo nga itong picture na to. Ito yung cervix mo. Dito tayo sa taas. Upper left. So, cervix mo, makikita nyo nandito yung ureter. So, pag nag-spread dito, nagkakaroon ng obstruction dyan. So, hence, magkakaroon ng urinary tract obstruction. And anong type of kidney pathology? yung associated pag may obstruction post-renal. Nasabi na. Post-renal. Okay? Pag may obstruction. Okay? Next, sakit tayo. Sa ovarian cyst naman. So the most common ovarian mass in young women is your follicular cyst. Okay? So it is due to an unruptured na Graafian follicle. So remember that your Graafian follicle, di ba? It induces the release, it releases estrogen. Okay? Therefore, mga follicular cyst, dahil mataas yung estrogen, nagkakaroon ng endometrial hyperplasia. Okay? Endometrial hyperplasia. Okay. And then, thicculotane cyst naman. Pag thicculotane cyst, okay, so these are associated with choriocarcinoma, okay, and your hydatidiform mole. Okay? So these cysts are due to excessive gonadotropin stimulation naman. Okay. Next, ovarian neoplasm. Kung kanina testicular neoplasm, nabanggit natin yung germ cell tumor and sex cord tumor. Pag ovarian neoplasm, idagdag natin yung mga epithelial tumors. Okay, epithelial tumors. As you can see, it is associated with the surface epithelium. Ito, the surface epithelium. Pag germ cell, galing sa egg. So kasi di ba, remember, egg, so para hindi niyo makalimutan, the egg cell, di ba, para siyang progenitor cell, andyan lahat ng mga cells na pwedeng maging tao in the future, no? So andyan yung mga germ cells. Kaya dyan nanggagaling yung germ cell tumors. Gets ba? And then the follicle and the cortex will give rise to sex cord stromal tumors. Okay? And the most common among these is your epithelial tumors. Okay? Among the three. Okay, isa-isahin natin. So your epithelial tumors can be serous. Okay? They can be mucinous. Okay? Kapag epithelial tumors, remember, you have to check for what tumor marker, your CA1, 2, 5. Okay? Ang palatandaan ko dito, yung 2 and 5 mukha siyang ovary. Ganyan yung siya drawing. So CA1 to 5 for ovarian neoplasms. Okay? Tapos, so those are your mucinous, those are your epithelial tumors. What are your germ cell tumors naman? You have your teratomas, your yolk sac tumor, and dysgerminoma. Okay? Pagka sinabing germ cell tumor, di ba sabi ko germ cell para siyang galing sa progenitor cell, di ba? So kaya niyang maging para siyang dream big sila. Sila yung mga dream big tumors kasi they can be what they want to be. Just like teratoma, di ba? Gusto kong maging buhok, gusto kong maging ngipin. Okay? So yun yung para mas madali nyo silang maalala, teratomas, kay yolk sac tumor. Okay? And then dysgerminoma, pag they just want to be, they just want to remain undifferentiated. Okay? And then next are your mga different types of sex cord tumors. You have your granulosa cell, you have your Sertoli, and your Leydig, which were discussed earlier also in your testicular pathologies. And lastly, yung fibromas for your sex cord tumors. So isa-isahin natin sila. So let's start with your mucinous. Okay, your mucinous is an example of an epithelial tumor, di ba? But mucinous neoplasms of the ovary, okay, pag nag-spill siya sa ating what do you call this, peritoneal cavity, it will cause pseudomyxoma peritonei. Okay, so remember that. Serous naman, it's the most common ovarian neoplasm. Okay, it's also the most common malignant ovarian neoplasm. So mag-iiba lang yung naming, no? Pagka benign, it's cystadenoma. Pag malignant, cystadenocarcinoma. Okay? So those are your serous neoplasm. Pag most common ovarian neoplasm, either benign, ito yung benign, cystadenoma yung benign, cystadenocarcinoma yung malignant. Next, let's go to teratoma. So we differentiated na mature, we said na teratomas can have mature and immature. So by the way pala, sa part na to, I'm just pointing out the most important terms that you have to remember with the different ovarian tumors. Okay? Okay, so let's go back. So teratomas, they can be mature or immature. Kapag mature, yan na. Nag-mature siya sa gusto niyang maging. Okay? Meron na siyang hair, meron na siyang teeth, ayan, meron na siyang sebum, ayan. So as you can see doon sa lower left picture, no? So that's a mature teratoma. And dahil mature siya, okay? It's wait lang. It's benign, okay? Pag immature, it contains fetal tissues or neuroectoderm and it's malignant. Ang palatandaan ko dito, immature siya, so malignant siya, para siyang laging nagagalit, ganyan. So immature, nagagalit, so malignant. Okay? Pero pag mature na siya, okay, kaya na niyang intindihin ang mga bagay-bagay sa buhay, kaya benign. Okay? So yun lang yung memory aid ko for that. And then your yolk sac tumor naman, okay, it's related to your Schiller-Duval, di ba? Schillio, di ba? Kasi it's an aggressive type of tumor. And then this germinoma, okay, fried egg appearance as similar dun sa testicular cancer na na-mention earlier. And then your granulosa cell tumor, it's associated with your Karl-Exner bodies. Karl-Exner, okay, for you to remember, call granny, call lola, call granny, Karl-Exner bodies. Then we have your Sertoli and Leydig, which is associated with virilization. Remember that your Leydig releases androgens, di ba? And increased level of androgen will cause virilization. And lastly, fibroma can present with Meigs syndrome. Okay? Meigs syndrome is, ano yung tatlo? Ovarian fibroma, ascites, and pleural effusion. Okay, ovarian fibroma, ascites, and pleural effusion. So ito lang, isang picture lang yan ng pseudomyxoma peritoneae. Nasaan yung pseudomyxoma? Ito yan. So mucinous substances na nag-spill sa ating peritoneal cavity. Okay? Due to a mucinous neoplasm of the ovary. Pwede rin siya sa appendix actually. Okay? Next, let's differentiate now the different uterine pathologies. So tapos na tayo sa ovary, uterus naman. So differentiate natin si adenomyosis with your endometriosis. So pagka adenomyosis, nauna yung PE. So pag adenomyosis, sa history, sasabihin ng pasyente, meron siyang abnormal uterine bleeding, lagi siyang dinudugo, may dysmenorrhea. Very important yung dysmenorrhea in the history. And kapag pinalpate mo, anong mafe-feel mo? It's uniformly enlarged. Tinanong to sa amin nung PrevMed about adenomyosis. So uniformly enlarged uterus, adenomyosis, automatic. Pero let's differentiate it with endometriosis. Pag endometriosis, ang presentation niya is cyclic pelvic pain. Okay? Kasi, di ba, ano ba yung common sa adenomyosis and endometriosis? Meron silang endometrium na naka-implant sa other parts maliban sa endometrium itself, sa uterine cavity. Okay? Sa adenomyosis, na-implant siya saan? Sa adenomyosis, na-implant siya sa myometrium. Sa endometriosis, na-implant siya kung saan-saan, which is most common sa ovary. Right? So, yun yung similarities nitong dalawang to, endometriosis and adenomyosis, ay may endometrial tissue sa other parts. Sa endometriosis, sa ibang lugar, maliban sa myometrium. Pag myometrium, that's adenomyosis. Okay? Next, leiomyoma. So, ito yung tinatawag na myoma. In the history, sasabihin ng patient, pwede siyang may abnormal uterine bleeding or pwedeng wala. No? Pwedeng in-ultrasound siya and then nakita nyo lang na may nodular masses doon sa uterus. Okay? In the physical exam, compared to your adenomyosis, no, ito ay may nodular masses naman sa uterus. Okay? And ang pathology, world pattern of smooth muscle bundles. Okay? So, yan yung main pathology. then uterine pathology, particularly your endometrial cancer, we can divide them into two, type 1 and type 2. Pag type 1, yan yung endometrioid. Okay? Type 2, ito yung serous. Okay? Pag clinical background, paano natin sila ma-differentiate based on the clinical background? Pag sinabing type 1, okay, sila ay due to an unopposed estrogen. Ano ba yung unopposed estrogen? Example, kunwari, nagtitake ka ng mga OCPs, ganyan. Or for example, you had wala kang baby or hindi ka nagkaroon ng baby throughout the rest of your life kasi ano ba nangyayari pag nagiging pregnant ka, di ba bumababa yung level ng estrogen. So kapag nulliparity, di ba? Ang nangyayari is continuously exposed ka to estrogen. Obesity can also be associated with this one kasi remember that fats, peripheral fats, diba, can convert your testosterone to estrogen. Okay? Your type 2, it's associated with atrophy of the uterine cavity. Okay? And then, mutation for your endometrioid type is your P10, while for your type 2 is your TP53. Pag P10, tandaan nyo, hin-highlight ko na siya dyan, N for P10, N for endometrioid. Okay? And then age is usually younger, no? Pagka type 1, mas matanda yung type 2. Okay? Sino yung mas aggressive dyan? Si type 2. Okay? Mas aggressive si type 2. Okay? Pag pangit, serious, no? Pangit, serious, atrophy. Okay, atrophy, pangit din yung cells, no? Nag-atrophy na. So remember pangit, type 2. Okay? And lastly, in our discussion, we have the breast pathologies. So konti na lang to. So I just want you to know about the different clinical pearls, no? Na pag kasi mahirap i-differentiate yung mga different breast pathologies based on the clinical presentations, no? Pero pwede nyo silang gamitin as clues, no? Kapag kasi ang gold standard, di ba, to differentiate your diagnosis in breast pathologies ay biopsy, di ba? Pero they can be used to help you aid in the diagnosis. Okay. Pag yung patient nag-present with pain, you will consider you will think of pathologies that are benign usually, no? Pag may inflammation, think of infectious. Usually infectious yan. Pero may isang cancer na nagpresent with an inflammatory reaction. That's your inflammatory carcinoma. Discuss natin later. And kapag ka may palpable mass, unang-una mong isipin, pwedeng cyst, pwedeng fibroids, wrong spelling, fibroids, no? And carcinoma. Pero pag may nipple discharge, no, you suspect cancer. Okay? Then, ano naman yung mga different mammographic findings? Pag rounded densities, large, tsaka konti lang, no? Tsaka hindi kumpul-kumpul, that can be benign. So think of benign pathologies. Pag irregular densities, think of malignant. Okay. Next, hinighlight ko to. So this is found in your USMLE step 1, no? Kasi it summarizes everything, no? Na kung saan nang gagaling yung mga different pathologies. So, tingnan natin. So, ang ginawa ko dito, I'll give a clinical background and I'll give the primary impression and the important notes to remember. So, kunwari, dumating sa inyo yung pasyente, 20 to 50 years old, premenstrual breast pain or lumps, ganyan. Nag-present siya with premenstrual breast pain or sumasakit yung dede niya kapag bago siya datnan, no? So primary impression, fibrocystic changes. Okay? So related to blue dome cyst. Pag naman yung pasyente, sabi niya, natamaan kasi ako dati, tapos meron ako nakakapa na bukol dito sa area ng dede. Okay? Consider fat necrosis. Okay? So it's due to a necrotic fat naman. Okay. Kunwari, the patient is less than 35. Small, well-defined mass, may nakapa siya sa breast niya, no? Mobile, which is less likely a malignant pathology, di ba, pag mobile. And then, increased size with increased estrogen. So, you consider the most common, your fibroadenomas. Okay? So, it's a tumor of fibrous tissues and glands. Pag serous or bloody discharge, think of intraductal papilloma naman. Okay? So intraductal papilloma. As you can see doon sa picture, no, saan siya makikita? Doon sa ducts. Okay? So pag nasasagi siya, pwede siya mag-bleed. Okay? So can present with serious or bloody discharge. And then, for example, the patient naman presents with old age, no, age 50, large mass. The keyword here is large mass. The primary, pero wala siyang significant systemic sign, meaning hindi siya probably malignant, no? So the primary impression should be phylloides tumor. Okay? Ang important to note about phylloides tumor is your leaf-like lobulation. But some may become malignant. Okay? Lahat ng mga diniscuss natin earlier from phylloides going back, all of those are all benign. Okay? Now we go to breast cancer or malignant. Okay? So usually these are seen during what age? Okay? Postmenopausal. And the most common location sa breast ay sa upper outer kasi dun yung pinakamadaming breast tissues. No? Dimpling is associated with Cooper's ligament, di ba? And ano yung mga clinical buzzwords na kailangan yung tandaan? BRCA1, BRCA2, think of breast cancer. Pag BRCA2, men, breast cancer, no? And increased estrogen exposure. Ano nga yung mga conditions na mataas yung exposure sa estrogen? Nulliparity, di ba? Postmenopausal obesity, di ba? Sabi ko kanina, adipose tissue converts your testosterone to your estrogen. And absence of breastfeeding. Okay? So just to give a quick summary of the molecular subtypes, so we have 3, luminal A, luminal B, HER2, and triple negative. Pagka ER positive, automatic, di mo na kailangan mag-isip, luminal yan, luminal A or B. Ang difference lang nila, si luminal B has a high proliferation index and the treatment is tamoxifen. Because tamoxifen, remember, it is an estrogen receptor partial agonist. Okay? Estrogen receptor partial agonist. Then, pag meron ng positive na HER2 receptor, automatic HER2 enriched. Okay? Triple negative, wala lahat. Walang receptor. Walang HER2, walang ERPR. Okay? Proliferation ng dalawang remaining ay mataas compared to your luminal B. The treatment for HER2 is trastuzumab. Treatment for triple negative ay mga PD-L1 inhibitors. Okay. So, puntahan natin yung mga carcinoma in situ summaries. No? We have DCIS or your ductal carcinoma in situ and your lobular carcinoma in situ. Okay? For the two, intact yung basement membrane nila. Remember, in situ. Diba? Hindi pa siya nag-cross sa ating basement membrane. Okay. For DCIS, usually meron niyang lobular disruption. May necrosis yan with associated calcification. And ito, if you remember earlier, no? DCIS is associated with Paget's disease. Okay? Pag sinabing Paget, yung cancer cells, no, nag-extend na towards the palabas doon sa nipple area and nagrepresent siya as eczematous patches or reddish patches as you can see doon sa picture, di ba? So reddish patches. Yeah. So that is your Paget's disease and the bilaterality of your disease is bilateral sa LCIS, okay? And unilateral sa DCIS. Okay. Now we go to invasive carcinomas. Buzzwords lang. No? Pag invasive ductal, it's hard. Bakit siya hard? Because of a prominent dysplasia. No? Mataas yung dysplasia na nakikita sa mga invasive ductal carcinomas. Invasive lobular presents rarely with mass kasi wala siyang masyadong desmoplasia. Medullary presents with soft mass. Okay? Invasive lobular will present with Indian filing. As you can see dun sa picture, Indian filing parang isang linear cell part, ano tawag din? Isang linear cells lang sila. Okay, linear lang yung formation ng mga cells. Dahil mababa yung tinatawag nating E-cadherin. So low, low E-cadherin. Okay, low E-cadherin. Okay, Indian fighting. So medullary, anaplastic cells yung presentation. And kapag ka-inflammatory, ang presentation niyan, di ba? Peau d'orange. If you remember, di ba? If inflammatory kanina, sabi ko ano yung consider nyo mainly? It should be your infections, di ba? Pero rarely it can cause your inflammatory. It can be due to inflammatory carcinoma. So, peau d'orange. Right? So, yan yung peau d'orange. Okay. So, that's it for your genesis pathology under kidneys, lower urinary tracts, the male and female reproductive pathologies, and your breast pathologies. Okay? So, see you next time. Okay? Aral na mabuti. And remember na mag-aral kayo para sa pasyente ninyo. Okay? Not only to pass the boards. Okay? So, for you to become great doctors in the future. Okay? Bye-bye. Good luck.